Which of the following is most likely the cause? A 58-year-old man undergoes a right hemicolectomy for colon cancer. On post-operative day 2, he develops mild dyspnea and low-grade fever. Pulse is 104, respiratory rate is 22, BP is 128/74, SpO2 is 91% on room air. Lungs show decreased breath sounds at the base of the right lung. Chest X-ray shows opacification on the right lower lobe with elevation of the right hemidiaphragm and mediastinal shift towards the opacified side. Okay. It's not pulmonary embolism. It is, okay, other options. It's not bronchial obstruction causing resorption, atelectasis, pleural effusion, ARDS pneumonia. Okay. Okay, for pneumonia, it has to be consolidation. Here it is opacities. So also ARDS will ARDS. I don't think you can localize ARDS. Maybe atelectasis, I guess, or option C.
Okay, so you want to pick option C.
Yes.
Yeah, I think I was going between C and D, but they said there is a mediastinal shift. So I think atelectasis can push it to like the affected side. So I'll go with C too.
Okay. What about you both? Both of you. So I will choose C.
Yes, same here.
Okay. So basically, in this scenario, they are asking you which of the following is the most likely cause. If we read the scenario again, the patient is on post-operative day 2. Then there are symptoms like fever, tachycardia, and then we have mild hypoxemia. Okay, when you look at the chest X-ray, it will show a mediastinal. It will show opacification of the right lower lobe with the elevation of right hemidiaphragm and mediastinal shift, which is a classic clue towards a lesion. And diaphragmatic elevation is also going to give you a clue, loss of volume. So when you read the scenario again, it's a post-op patient. Usually after day 1 to 2, this is a classic timing for mucus plug induced bronchial obstruction. And then the symptoms like fever, tachycardia, mild hypoxemia, these are again common immediate post-op findings. Chest X-ray with a mediastinal shift towards a lesion plus diaphragmatic elevation is all. They both give you a clue towards the loss of volume that can lead to atelectasis. Okay, now let's see what are the options. They are asking you what the cause. In the first option we have is pulmonary embolism. Pulmonary embolism can occur after it could be a finding post-op, but it it usually occur after 3 to 5 days post-op. Plus, when you do the chest X-ray is often normal or sometimes shows the wedge infarct, and there is not going to be any mediastinal shift towards the lesion. So this is not pulmonary embolism. Then we have pneumonia. Pneumonia basically need again more than 48 hours plus sorry, pneumonia need at least 48 or more than 48 hours to develop. Plus there is going to be a purulent sputum, productive cough, and chest X-ray can show air bronchogram and no mediastinal shift. So this is not pneumonia. Then we have pleural effusion, option D. Pleural effusion, in case of pleural effusion, the fluid pushes the mediastinum away from the opacified side, which means in this case, the shift is going to be away from the opacified side. So this is again a wrong option in this case. Then we have ARDS. ARDS is a bilateral diffuse. In the case of ARDS, you're going to have a bilateral diffuse opacities. You pick it right here. And it also occur approximately after 3 to 5 days post-op. In the setting of sepsis or trauma, there is going to be no focal shift. So ARDS is the incorrect answer. The correct answer is bronchial obstruction causing resorptive atelectasis. So what is the pathophysiology? Basically, what happens that after 1 to 2 days post-op, the mucus plug induced bronchial obstruction occur, and because of this obstruction, the air is trapped, and the trapped air is absorbed by pulmonary capillaries. And once the trapped air is absorbed, it can lead to alveolar collapse. Clear?
Yes.
Yes.
So the key points you need to remember: the timing. You should have an idea that when it comes to the early post-op, which means before 48 hours or up to 48 hours, think about atelectasis. And when they're talking about the late post-op things like after 3 days, then think about pneumonia and pulmonary embolism. The second important point for exam is mediastinal shift. If the mediastinal shift direction is towards the lesion, it is a clue for the volume loss. You can think about atelectasis. And if the mediastinal shift is away from the lesion, it is a clue for the space occupying lesion like effusion and tension pneumothorax. Clear?
Okay.
So now let's talk about atelectasis. Atelectasis is basically collapse or incomplete expansion of alveoli. Because of the loss of lung volume, there is VQ mismatch and hypoxemia. This common post-surgical cause of low-grade fever and hypoxia, as we have seen in this patient. There are different types and mechanisms of atelectasis. It could be resorptive, or you can say obstruction. There could be compression. There could be contraction, or it could be adhesive. So resorption or obstruction, the mechanism is airway obstruction that can lead to trapped air absorbed by the capillaries and can lead to alveolar collapse. The key features are post-op mucus plug, foreign body, or bronchial tumor or mediastinum is going to shift towards a lesion. Then we have compression. The external pressure on the lung from the fluid or air in the pleural space can lead to compression atelectasis. It could be because of pleural effusion, tension pneumothorax, and the mediastinum is going to be shift away from the lesion. Then the contraction atelectasis, or you also call it as cicatricial atelectasis. There is going to be a fibrotic change that can pull alveoli close, and it is common in post-TB, sarcoid disease, radiation, and ARDS fibrosis. So basically, in contraction atelectasis, there are going to be fibrotic changes, and it is associated with post-TB, sarcoid, radiation, and ARDS fibrosis. Then we have adhesive or surfactant deficiency, in which there is a loss of surfactant, that can increase the surface tension and lead to collapse. It is common in neonatal ARDS and ARDS in general. So this is just the general information from your step one. Now let's talk about the associations, which is important, or epidemiology. The most common cause of post-op fever within first 48 hours. Atelectasis is the most common cause of post-op fever within first 48 hours. This is an important thing to remember. In any scenario, whenever there is a post-op patient within first 48 hours presenting to you with a fever, think about atelectasis until proven otherwise, because it's the most common factor. Then we have a certain predisposing factors, like it can lead to shallow breathing due to pain or anesthesia, impaired cough reflex because of the opioid or neuromuscular blockage, abdominal or thoracic surgery, and it is also common in smoker and COPD patients. So these are the predisposing factors for atelectasis. Now let's talk about the radiographic findings or X-ray findings that you can see in the patient with atelectasis. On chest X-ray or on a radiograph, you can see homogeneous opacity. This homogeneous opacity is basically a collapsed segment or the lobe of the lung. You can have elevation of hemidiaphragm. This is because of the volume loss. You can see the crowding of ribs or narrow intercostal space. This is because of the, again, volume loss. Then you have mediastinal shift. This is towards the lesion. Then you can also see compensatory hyperinflation of opposite lung. So the opposite lung, because the opposite lung now have to work more, there could be a compensatory hyperinflation of the opposite lung. So a classic clues you can get on exam, whenever there is a collapse for atelectasis, the mediastinum will shift towards the opacity. And whenever there is an effusion, the mediastinum is going to be shift away from the lesion. Clear?
Yes.
Now let's talk about pathophysiology and consequences of atelectasis. Alveolar collapse leading to decreased ventilation, decreased VQ mismatch or shunt that can lead to hypoxemia. That's why we see mild hypoxemia in this case as well. Another thing is there is going to be a reflex pulmonary vasoconstriction that will further decrease the VQ. You can also have mild fever due to cytokine release from the resolved cell debris. So basically, the fever in this case is not because of the infection. The fever in this case is because of the cytokine release from the absorbed cell, from the resolved cell debris. What are the clinical features? Usually, your patient is going to be having a post-op day 1 or 2, presenting to you with a low-grade fever, less than 38.5, tachycardia, mild hypoxia with no sputum. On examination, there is going to be decreased breath sounds, dullness to percussion, decreased tactile fremitus. On labs, you can see mild respiratory alkalosis from tachypnea. On imaging, you can see ipsilateral diaphragm elevation plus shift towards the obesity. Clear?
Yes.
So how you can make a diagnosis? First of all, look at the clinical pattern, then the timing, chest X-ray, exclude the pneumonia, and then usually the second common is pneumonia, so you have to exclude the pneumonia, and then you can use check pulse oximetry and ABG if hypoxia is severe. Then let's talk about the management. First of all, let's see that what is our goal. If our goal is prevention, like we have a post-op patient and we are our goal is to prevent atelectasis in that patient. So for prevention, what we are going to do, we can do early ambulation, incentive spirometry, deep breathing exercises, adequate pain control, because if you do the adequate pain control, it is mandatory to allow the cuffing. So basically, there will be early ambulation, incentive spirometry, deep breathing exercises, and adequate pain control. You can do this to prevent the atelectasis post-op. But let's suppose if the atelectasis has already occurred, then you have to do incentive spirometry with chest physiotherapy plus position change. If along with atelectasis, obstruction is suspected, then you can do bronchoscopy to remove the mucus plug or foreign body. And if the hypoxia is severe, then you can add supplemental oxygen. And if nothing works, then sometimes you have to do intubation or PEEP. Clear?
Okay.
In case of atelectasis, one thing you need to remember that there is no indication of antibiotic. Whenever you are picking up the management option, antibiotic is not recommended because we have already established that the fever is not because of infection, it is because of the cytokine release. So there is no indication of antibiotics unless there is some secondary infection like pneumonia and that is confirmed. Then you can add antibiotics.
Is chest physiotherapy deep breathing exercises?
Sorry. just just physiotherapy and posture change.
Okay. So what did they do in chest physiotherapy? They do like breathing or
In a
different
chest
breathing exercise?
physiotherapy, we basically, there are different techniques, but usually that is used in the hospital is, um, how would I explain? You ask the patient to be in a sitting position, and then okay. So basically, first of all, you will see that you will assess the lung base, or you will see that which part of the lung. Yep, now we are discussing the chest physiotherapy in post-op atelectasis patients. It is different in different patients, but particularly for atelectasis patients, first of all, you are going to assess the lung base or the part of the lung which is collapsed. It is usually the lower lung lobes. Then you put the patient on a lateral decubitus or prone position with the affected side uppermost. So you keep the affected side up and the other side down for the postural drainage. And then you will gently percuss the chest wall for 3 to 5 minutes per segment. You can see a YouTube video to get a good idea that how we percuss. It's like we simply in hospitals we just, what I can say, you can gently percuss the both sides of the back or both sides of the front. Usually we do it from the downside to the upside so that the drainage can be done easily, and we gently percuss the chest wall for usually 3 to 5 minutes per segment, and ask the patient to do the deep breathing and encourage the coughing, or sometimes we can also use suction to remove the loosened secretions. And this is generally repeated 2 to 4 times per day until the oxygenation and chest x-ray is improved. Clear?
Yes.
We have discussed the management. If you have a patient with hypoxia post-op day 4, along with the hypoxia there is a fever and purulent sputum, what will be your diagnosis?
Pneumonia?
Yeah.
Ye- Yes. Now let's talk about the complications. For example, if a patient is having atelectasis and the patient is not treated, then what could be the complications? The complications are secondary pneumonia, superattitude infection, hypoxemia leading to ARDS if it is massive, or the patient can have post-op respiratory failure. Clear?
Yes.
So the most important point is early post-op patient within 48 hours presenting to you with a fever, hypoxia, chest X-ray opacities. With a shift towards a lesion, think about atelectasis due to mucus plug, and it can be prevented with incentive spirometry and treat with bronchoscopy if needed. We have covered acute respiratory distress in the previous lecture. Not yet. Okay. Okay, please read the scenario.
Which of the following best explains the patient's hypoxemia? A 46-year-old man is admitted with a severe abdominal pain due to acute pancreatitis. On day 3 of hospitalization, he develops increasing dyspnea. Vital signs: temperature is 38.2, blood pressure is 94/60, that's very low. Heart rate is 122, elevated. Respiratory is 30. SpO2 is 84 on 6 liters of nasal oxygen. Lung exam, there is a diffuse crackles bilaterally. Chest x-ray shows bilateral alveolar infiltrates without cardiomegaly or pleural effusion. Echo shows normal LV function. PaO2 is 55, that's also low. And then FiO2 is 0.5. So which of the following best explains this patient's hypoxemia? Alveoli hypoventilation from narcotic use, no. Pulmonary embolism with VQ mismatch, no. Non-cardiogenic pulmonary edema due to increased alveolar capillary permeability. I'll hold that. Pulmonary venous hypertension from LV failure. Diffusion limitation from interstitial fibrosis. I'll go with option C.
Okay.
Yes, this looks like acute onset ARDS after pancreatitis, so I would go with option C.
Me too, because ARDS causes the pro-cytokine inflammatory cytokine release. So that causes the increased alveolar capillary permeability. So yeah, I would go with option C.
Also, me, also with the X-ray findings, because it will go with acute respiratory distress syndrome. I can't hear you clearly, and I can't understand your explanation. Can you please repeat? No, acute respiratory distress syndrome. I'll just say also, but because of the X-ray findings. Okay. So basically, when you look at the scenario, they have mentioned a young man, a 46-year-old man is admitted with a severe abdominal pain due to acute pancreatitis. This is the first clue. There will be, because when there is acute pancreatitis, it can lead to systemic inflammatory cytokine release like interleukin 6, interleukin 1, and TNF alpha. These inflammatory cytokines can lead to endothelial damage in the pulmonary capillaries and can lead to leak of protein-rich fluid into the alveoli, leading to loss of surfactant plus alveolar collapse plus severe shunt hypoxemia. When we look at the other findings, your PaO2 FiO2 is equal to 55 by PO2 is 55 on FiO2 0.5. First of all, let's understand that what is PaO2 by FiO2 ratio. PaO2 is basically your partial pressure of arterial oxygen, which is measured from ABCs. In this case, it is 55. FiO2 is a fraction of inspired oxygen and it is measured in decimals. So it is 0.5. 0.5 actually means 50% of oxygen, but it is measured in decimals, so it is 0.5 over here. When you do this ratio, take this ratio 55 divided by 0.5, it turned out to be 110 mmHg. This is clear?
So this is normal or for this patient you're saying?
No. This is calculated for this patient.
Okay.
So this is 110 mmHg. Then we have for ARDS severity, we have a Berlin criteria. According to the Berlin criteria, if your PiO2 or FiO2 ratio is between 200 to 300, it is mild. And if it is between 100 to 200, it is moderate. And if it is less than 100, it is severe. So for this patient having FPO2 or FiO2 ratio 110, it falls in the category of moderate ARDS, right?
Yes.
Yes.
If PiO2 or FiO2 ratio is above 300, or you can say if it is below 300, this is the hallmark of ARDS. So whenever your PaO2 or FiO2 ratio is below 300, it is ARDS. Then you categorize it, is it a mild ARDS or it's a moderate ARDS or a severe ARDS? This is clear.
Yes.
So we have a severe pancreatitis case leading to endothelial damage, loss of protein-rich fluid into the alveoli, loss of surfactant plus alveolar collapse plus severe shunt hypoxemia, and PaO2 over FiO2 ratio is 110, which is less than 300. On X-ray, bilateral alveolar infiltrates without cardiomegaly. So this is a clue that the cause is not cardiogenic. What are the other options? They are asking you which of the following best explains the patient's hypoxemia. The option A is Alveolar hypoventilation from narcotic use. Narcotic hypoventilation can lead to increase PaCO2, plus there should be normal X-ray. So this is not the correct answer. When you look at the option B, pulmonary embolism with VQ mismatch, usually asymmetric, clear. It is usually asymmetric, and there should be clear lungs. Or wedge infarct with no diffuse alveolar infiltrates. Then we have option D, pulmonary venous hypertension from left ventricular failure. It will show pulmonary vascular congestion. Plus there is cardiomegaly. Plus there is elevated pulmonary capillary wedge pressure, which should be more than 18 mmHg. Because these findings are missing, so this is the incorrect answer. Then we have option E, which is fibrosis, diffuse limitation from the interstitial fibrosis. If it is fibrosis, then they might have mentioned chronic dyspnea. It should have a gradual progression, not a typical acute ARDS pattern. So this is also incorrect. The correct answer is non-cardiogenic pulmonary edema due to increased alveolar capillary permeability. Clear?
Okay.
So let's talk about acute respiratory distress syndrome. ARDS or acute respiratory distress syndrome is an acute diffuse inflammatory lung injury that can increase the alveolar capillary permeability. That can lead to non cardiogenic pulmonary edema along with refractory hypoxemia and decreased lung compliance, and it usually occurs within 1 week of a known trigger. As in this case, there is a history of acute pancreatitis, and the symptoms on third day of hospitalization, the symptoms occur. So the symptoms will develop within 1 week of known insult. Clear?
Yes.
Now the triggers could be the sepsis, which is the most common one. It could be trauma, it could be pancreatitis, aspiration, massive transfusion. Or it could be pneumonia or COVID-19 infection or toxic inhalation. Any of these could be the triggers. It can lead to systemic inflammation, neutrophil activation, leading to release of proteases and reactive oxygen species. Endothelial and epithelial damage can occur that cause the protein-rich fluid leak into the alveoli. It can lead to formation of hyaline membrane, loss of surfactant, leading to alveolar collapse. It can result in shunt physiology, which means that VQ ratio is equal to 0, and that can lead to refractory hypoxemia despite of giving oxygen therapy. Then we have discussed the Berlin diagnostic criteria of ARDS. According to the Berlin diagnostic criteria, um, few things that you should consider. The first is timing. It should occur within 1 week of the known clinical insult or a new respiratory symptoms. Then we have chest imaging. You have bilateral opacities not fully explained by effusion, nodules, or capillary collapse. Then we have origin of edema. The origin of edema should not be because of the heart failure or volume overload. So your pulmonary capillary wedge pressure should be less than or equal to 18 mmHg. And then we have oxygenation, PaO2 over FiO2. We have discussed the criteria when we categorize it in mild, moderate, and severe category. For mild, it should be between 200 to 300. For moderate, it should be between 100 to 200. For severe, it should be less than 100. Clear?
Okay.
Few important clinical clues you can see in the exam scenarios. Usually, whenever they give you a scenario of sepsis or pancreatitis, they give you a clue that within 3 to 5 days, ARDS occurs. When they relate it with aspiration pneumonia, within 12 to 24 hours after respiration, ARDS occurs. When they give you a clue of massive transfusion, they associate with the transfusion related acute lung injury. For trauma and fractures, fat embolism syndrome can lead to ARDS. Clear?
Yes.
Now let's talk about management. The first thing you do is immediate stabilization. You have to identify and treat the underlying cause, like sepsis, pancreatitis, or trauma. Then you can give supplemental oxygen. If severe, and initiate mechanical ventilation with low tidal volume. You can apply PEEP in 5 to 15 centimeter of water to prevent alveolar collapse and recruit atelectic areas. Clear?
Okay.
Then there are a few ventilation strategies. You can see this U1. What should be your ventilation strategy? Tidal volume. The target is between 4 to 8. The purpose is to prevent volume related trauma. The plateau pressure less than 30 centimeter of water. The purpose is to avoid barotrauma. FiO2 less than or equal to 60% as soon as possible to prevent oxygen toxicity. Sleep is to start at 5 and then titrate to maintain PaO2 between 55 to 80 to prevent alveolar collapse. Clear?
Okay.
The adjunct therapies or add-ons could be put the patient on the prone position to improve the oxygenation by recruiting the dorsal alveoli. To give the prone position. Then there is neuromuscular blockage. A short course of less than 48 hours for ventilatory synchronization is given. Conservative management to stabilize the patient hemodynamically. ECMO, extracorporeal membrane oxygenation, for refractory hypoxemia in young, otherwise healthy patients. Now let's talk about the therapies that are not recommended in case of ARDS. Routine steroids. Routine steroids are not recommended unless specific indications like COVID-19 ARDS or refractory late phase is present. High tidal volume ventilation is not recommended because it will increase the mortality because of volume related trauma, and diuretics are not recommended unless there is a fluid overload. So routinely, three therapies should be avoided. Routine steroid use until unless there is some specific indication like COVID or ARDS. High tidal volume ventilation because it can lead to increased mortality because of the volume related trauma. Diuretics until unless they have specifically mentioned that there is fluid overload. Clear? This is clear to all of you?
Mhm.
Then let's talk about the complications. When it comes to the complication, we have barotrauma, pneumothorax from high pressure, nosocomial pneumonia from prolonged ventilation, or patient can go into the multi-organ failure if systemic inflammation persists. So if I summarize the management, you have to treat the underlying cause. you put the patient on low tidal volume ventilation, apply PEEP, then go for the then you have to put the patient in a prone position. If PaO2 or FiO2 is less than 150, restrict the fluids, and ECMO is recommended if in refractory cases. So ARDS is clear to all of you?
Yes.
Okay, please read the next scenario. Hello.
Which of the following is the most likely diagnosis? A 29-year-old from Arizona presents with fever, dry cough, and chest pain for 10 days. He recently returned from a camping trip in southern Arizona. Chest x-ray shows a right lower lobe infiltrate with hilar adenopathy. Labs, there's eosinophilia present. Sputum culture shows spherules containing endospores. Which of the following is the most likely diagnosis? Histoplasmosis, blastomycosis, coccidiomycosis, cryptococcus, or aspergillosis. So this one, main clues are the location is Arizona, and has sputum that shows spherules with endospores. So I think that's a sign of coccidiomycosis.
Okay.
Yes, I would also pick coccidiomycosis because that is in the dry areas of California, Arizona. So, yeah, option C.
Okay.
Yeah, same here. Option C.
What's your answer, Bayan?
Bayan typed also option C.
Okay. So you guys picked the right clues, and because they have mentioned endemic area, south southwestern US. during Arizona, and there is an exposure of inhalation of uh, there is an exposure of inhalation from the soil. The pathology they are mentioned is the form spherules filled with the endospore in the tissue, and because they also have given the clues like 29-year-old man from Arizona present with a fever, dry cough, and chest pain for 10 days. And then they have mentioned the hint of Arizona. On chest X-ray, there are right lower lobe infiltrates with a higher lymphadenopathy. There are eosinophilia present, and then there are spherule containing endospores. They are asking about the diagnosis. So let's discuss the options. Histoplasma is common in Ohio and Mississippi River areas, and it is associated with the bird and bat droppings. Plus, there could be intracellular yeast in macrophages, not spherules. So, this is the incorrect answer. Plastomycosis is again east of Mississippi and Great Lake region, and the key clues for plastomycosis are broad-based budding yeast and skin or bone involvement, which is not mentioned over here. It's the incorrect answer. Cryptococcus is common in immunocompromised patients and it is associated with pigeon droppings. So, and it can cause meningoencephalitis, not the hilar adenopathy. So, this is also an incorrect answer. Aspergillus is also common in immunocompromised, particularly TB cavities, associated with the TB cavities, and you can see septate hyphae at acute angle on stain, not the spherules. So this is also an incorrect answer. So the correct answer is C, which is coccidioidomycosis. Clear?
Yes.
Now let's talk about fungal pneumonias. Fungal pneumonia is an important cause of subacute chronic pneumonia, especially in immunocompromised patients or specific endemic region. Like step 1, when we discuss fungal pneumonias, in step 2, our focus is on geography, because that's an important clue, geographic or demographic region. And then we also focus on host immune status. We also focus on radiologic patterns, and then we should talk about the appropriate antifungal therapies. The first we have is Histoplasma capsulatum. Histoplasma capsulatum is common in Mississippi and Ohio River Valley, and it's associated with the bird and bat droppings and caves. Then we have blastomyces. It is common in the eastern U.S. Great Lake region, and it is associated with decaying wood and soil. Then we have coccidiode, southwestern U.S. like Arizona, associated with the dry desert soil and dust storms. Then we have paragoccidiodes, Latin America and Brazil, and associated with the rural workers and soil. Then we have Aspergillus fumigatus, common worldwide and associated with the decaying vegetation, hospital air vents. Then we have Cryptococcus neoformans, again distributed worldwide, commonly associated with the pigeon droppings, and it is associated with urban exposure, HIV, AIDS. These kinds of hints can be seen in case of Cryptococcus neoformans. Then, if we talk about the diagnosis for histoplasma, you can have yeast inside the macrophages on microscopy and culture, and on serology and antigen, there is a urine and serum antigen test for the diagnosis of histoplasma. For blastomycosis, you can have a broad-based budding yeast, and for antigen and serum, you can use serum antigen, which is also known as which also cross-react with the histoplasma. Then for coccidioids, there are cephidiole with endospores larger than RBCs. And for serology, you do serology for IgG and IgM. For Cryptococcus, there is going to be encapsulated yeast on India ink stain or latex antigen. And for antigen serology, you have CR antigen or capsular antigen. Aspergillus microscopy and culture, septate hyphae at 45 angle on GMS stain. Antigen and serology, galactomannan antigen or PCR can be used. This is a simple basic information from your step 1, how to make the diagnosis. Now let's talk about some radiologic patterns which is important and given in the U world. When we talk about histoplasmosis, you can see patchy infiltrates that lead to calcified granulomas. So patchy infiltrates leading to calcified granulomas and mediastinal fibrosis, or you can say calcified nodes. Then we have blastomycosis, lobar consolidation, you can see skin ulcers or bone lesions. Then we have cocci, diadomycosis, you can see hilar adenopathy or thin walled cavities or nodules. Then we have aspergillus, fungal wall in cavity, or halo sign in immunocompromised patients. Then we have cryptococcus. You have diffuse interstitial pattern in AIDS patient. Clear?
Yes.
When it comes to the clinical features of fungal pneumonia, generally when it's a primary infection, you can have mild self-limiting flu-like symptoms. Um, when this is a disseminated condition, which usually occur in immunocompromised patients taking like HIV, transplant, or steroid taking patients, there would be a multi-organ involvement that can involve bone, skin, CNS, and adrenals. For chronic infections, TB-like fibrotic cavity disease is usually present in the upper lobes. Now let's talk about the treatment guidelines, which is important, again given in the U world as well. So the treatment guidelines are for histoplasma, you give itraconazole for 6 to 12 weeks.
Dr. Fatima, your phone battery is low.
Yeah. Let's try to cover this. I hope this will be done. हाँ जी बीच में 3 मिस किए histoplasma for the mild disease you give itraconazole for 6 to 12 weeks. For severe or disseminated you can give amphotericin B, and then you put the patient on itraconazole as a maintenance therapy. Then for blastomycosis, you can give itraconazole again for mild condition and amphotericin B for severe or disseminated. For coccidioids, usually self-limited, you can give fluconazole if the patient is high risk, pregnant, or immunocompromised. If the patient is pregnant, immunocompromised, then you can give fluconazole for the mild or localized disease, and for severe disseminated, again amphotericin B. For aspergillus, for the mild localized, you can give voriconazole. You can also add sorry. You can also add caspofungin if invasive. And for severe or disseminated condition, you can do surgical debridement if aspergilloma causes hemoptysis. Then you can get for cryptococcus. For mild localized condition, you can give amphotericin B plus flucytosine, and then you can give fluconazole for maintenance therapy, especially if there is a CNS infection. And for severe or disseminated conditions, you can give, especially if the pulmonary system is involved, then you can particularly give fluconazole. Clear?
Okay.
Mhm. The next topic we have is bacterial pneumonia. Before discussing bacterial pneumonia, I want you guys to just go through the topic of bacterial pneumonia from book, and then we'll continue uh, with the bacterial pneumonia on Monday, inshallah. How many algorithms we have covered in the last discussion? I think 6 algorithms, 7 algorithms. We have also covered treatment of menopause. Seven algorithms, right?
Yes.
So let's cover these 3 algorithms, and then on Monday we are going to revise the total 10 next algorithms. So this algorithm explains the management of endometriosis. First of all, if you have a suspected case of endometriosis, which means that you have a patient with the symptoms like chronic pelvic pain, dysmenorrhea, deep dyspareunia, and dyschezia. So if a woman presents with any of these classic symptoms, you are going to suspect endometriosis. Chronic pelvic pain, especially around the menstrual cycle, dysmenorrhea, which is painful period, dyspareunia, pain during intercourse, and dyschezia, painful bowel movements during menses. We are going to ask few questions before deciding the next step. First of all, you are going to ask, does she need a definite diagnosis? For example, If you ask her that does she need a definitive diagnosis, for example, she is having infertility or we need to rule out cancer, then you can ask that is there any concern for malignancy or adnexal mass. Then you can ask that does she have contraindications to hormonal therapy? For example, she can't take oral contraceptives due to clotting risk. Then you can ask is she willing to try empiric or non surgical therapy first? So you ask these few questions before deciding the next step. Let's suppose if she says no to these questions, like she's like there is no contraindication to the medical therapy, there is no need for the definite diagnosis, or she's not suspecting any cancer or malignancy or adnexal mass, and there is no history of infertility. So if her answer is no, that means that we do not urgently need surgery and there is no concern for cancer. So we can simply start with the medical or empiric therapy. You can give answers for pain control, plus you can give oral contraceptives to suppress the ovulation and endometrial proliferation. This is called the empiric therapy because you are treating based on the symptoms without confirming diagnosis surgically. Clear?
Okay.
If you have started this empiric therapy and the patient's symptoms are improved, you can continue the therapy. But if you have started the therapy and the patient's symptoms are still persistent, now you have to move towards the diagnostic laparoscopy. On the other hand, if the patient says yes to the answer, which means that she need a definite diagnosis or fertility evaluation, or you have concern about a mass, so the next step should be laparoscopy. During laparoscopy, you can visualize endometriotic lesion directly. You can excise or ablate them to relieve pain and improve the fertility. Clear?
Okay.
So, a few things you need to remember. The first line treatment, medical treatment is NSAIDs plus OCPs. The gold standard diagnostic test is laparoscopy with visualization and biopsy. And if they ask you about the definitive treatment, particularly for completed family, you pick the option total hysterectomy with bilateral salpingo-oophorectomy. Clear?
Yes.
Then we have this algorithm explaining approach to postmenopausal bleeding. If a patient, first of all, you have to identify the clinical problem. Any bleeding that occur after menopause, which means if there are no periods for more than or equal to 12 months, and then there is some bleeding, that is considered as abnormal until proven otherwise. The main goal of evaluating postmenopausal bleeding is to rule out endometrial cancer. So the first step you are going to do is to do transvaginal ultrasound and measure the endometrial thickness, the lining of the uterus. This is safe, quick, and non-invasive method to decide who needs a biopsy. So if you have done the transvaginal ultrasound and your interpretation is endometrial strip is less than or equal to 4 mm, there is a very low risk of cancer, so you can simply observe the patient. No biopsy is needed until bleeding reoccurs. But if the endometrial strip is above 4 mm, there is a possible risk of hyperplasia or malignancy. So now you can go for endometrial biopsy to rule out or to look for atypia or cancer. And if so, basically, when you interpret the biopsy, and then when you interpret the biopsy, if the biopsy results are benign or normal, then you can simply observe the patients. It could be atrophic endometrium or hormonal changes. So observation reassure the patient, and no further action is needed unless bleeding reoccur. But if the biopsy results shows atypia, neoplasia, or endometrial neoplasia, it it will give you a clue for a precancerous or cancerous lesion. Now you have to treat the patient. You put the patient on progestin therapy if fertility is desired, or no surgic or if a patient is not a surgical candidate, then you put the patient on progestin therapy. Otherwise, if they ask you about the definitive treatment, then definitive treatment will be surgery or hysterectomy. Clear?
Can you repeat the first step?
The first step is you will evaluate the postmenopausal bleeding, and you have two options. The first option for if the first option is you have to do the transvaginal ultrasound to look for the endometrium size, to check the endometrium size thickness. Sorry. Because this is safe, this is not invasive, so you usually start with the transvaginal ultrasound to look for the endometrium thickness, and then you proceed further. If you are confused that when we are going to do endometrial biopsy straight, we can go and do endometrial biopsy straight if the patient is having, if the transvaginal ultrasound was already done and the size of the endometrium is increased and now the patient is on follow up, or if the patient is having bleeding for a very long period of time, it's not the first time bleeding, then you can go for endometrial biopsy as well. Or if the patient is having a family history of endometrial cancer, let's suppose you have a patient with a family history of endometrial cancer, now having a recurrent bleeding episodes, and the previous transvaginal ultrasound already shown the thickness above 4 millimeter, then you can do biopsy directly. Clear?
Okay.
Yes.
Then let's talk about abnormal uterine bleeding and secondary amenorrhea evaluation. Abnormal uterine bleeding or secondary amenorrhea evaluation, when you are evaluating a patient for secondary amenorrhea, you will look at the age of the patient. If age is less than 45, or the age is 45 or above 45. Let's suppose, first of all, let's understand that what abnormal uterine bleeding is. Abnormal uterine bleeding is simply any change in the menstrual frequency, duration, or volume, which means that either it is too heavy or too long or irregular. And secondary amenorrhea is the absence of menses for more than 3 months if woman had regular periods before, or more than 6 months absence of the menses if she had irregular cycles previously. This is the definition of secondary amenorrhea. So you have two criteria. If you have a woman with the regular periods previously and now she's not having any period for for 3 months, you for more than 3 months you label it as secondary amenorrhea. But if a woman is having a history of irregular menses and now she is not having periods for more than 6 months, then you label it as secondary amenorrhea. So once you have established that patient is having abnormal uterine bleeding or secondary amenorrhea, the next step is always check the pregnancy. Always check the pregnancy regardless of the patient's age. The first step in any woman with a missed period or irregular bleeding is order a beta HCG to rule out pregnancy. Then the next step is, if age is less than 45 and HCG is positive, which means the patient is pregnant, so you will manage the patient accordingly. But if the HCG is negative, then you will proceed to the hormonal evaluation. You will check the FSH, TSH, and prolactin levels. Basically, if FSH is high, it will represent ovarian failure or premature ovarian insufficiency. If TSH is abnormal, it might represent a thyroid disease causing menstrual irregularity. If prolactin is high, it can represent prolactinoma or drug induced hyperprolactinemia. This will help you to identify the most common endocrine disorders of abnormal uterine bleeding and secondary amenorrhea in a woman of reproductive age. But if the age of the woman is above 45 or 45, then you can still start with beta HCG to rule out pregnancy, although very less likely, but you still do the beta HCG test. And after that, if beta HCG is positive, it will be a pregnancy, and if it is negative, then because usually no further hormonal evaluation is required in most of the cases, because menstrual irregularity in this age group is usually due to perimenopause. However, in selected cases, we can check TSH or prolactin to rule out galactorrhea or thyroid symptoms if there are galactorrhea or thyroid symptoms are present. Clear?
Yes.
Okay, so now we're done with the with 10 algorithms. So our last discussion from here onwards. I think we haven't discussed this one either. From this. So starting from this algorithm, there are 10 algorithms. All of you are supposed to devise these 10 algorithms, and we will discuss these 10 algorithms in our next class, inshallah. Let's just go through a topic of bacterial pneumonia. This is it for today. If you have any question, you can ask.
Dr. Fatima, can we cover the second cardiology question I shared with you?
Yes, you can. You have sent me. Let me check. Can you please send me the question again? Okay, no, I just found it.
I shared the explanation with you as well.
Okay. This was the question. I didn't get the explanation yet, but this was the question.
Which of the following is likely to be present on repeat echo? 26-year-old man is hospitalized for fever and chills. Blood culture grow gram-positive cocci in clusters. Chest exam is unremarkable. Echo shows a mobile density on the posterior mitral leaflet, but is otherwise unremarkable. On the third day of hospitalization, the patient exhibits shortness of breath and an inability to lie flat. On exam, bibasilar crackles are present. A 2 out of 6 hollow systolic murmur is heard at the apex. Which of the following is present on repeat echo?
Okay. So what is your answer?
So I was thinking that there's a density on the mitral valve. So with the hollow systolic murmur, this may be a sign of mitral regurgitation. And if there's mitral regurgitation, the left atrial size would be dilated, and the left ventricular size would be dilated, and the left ejection fraction, because but the blood will backflow into the atrium, and then there will be more blood volume that is into the ventricle. So therefore, the ejection fraction would be normal or increased. So option A.
Okay. And anybody else?
Yes, even I was thinking the same thing. We were doing this question together, and this was my reasoning too.
Okay. What about you, Linda?
Yeah, that looks like A if we're going with mitral regurgitation. Um, I'm a little bit confused with this question, but yeah, I think I'll go with A.
Or I was thinking that the ejection fraction could be low, so it could be option C.
Okay. Now let's read the scenario. Okay. So you have a young man, 26-year-old man, and has a staph aureus infection because the patient is having the blood culture grow gram-positive cocci in clusters. So this is a clue for a staphylococcal aureus infection. Echocardiogram shows a mobile density on posterior mitral valve, but is otherwise unremarkable. So, mobile density on posterior mitral valve is vegetation. On posterior mitral valve, the patient suddenly develops, on the third day of the hospitalization, develops shortness of breath, inability to lie flat. On examination, there is bibasilar crackle. There is 2 by 6 hollow systolic murmur heard at the apex. Which of the following is likely to be present on repeat echocardiogram? So basically, this patient is having acute mitral regurgitation. So, what happens in case of acute mitral regurgitation? Hemodynamic. What are the hemodynamic changes you can see in a patient with acute mitral regurgitation? When the mitral valve suddenly becomes incompetent or there is regurgitation, the blood is going to flow back into left atrium, right?
Yes.
So now because this is an acute condition or the symptoms just appear, the left atrium does not has had no time to dilate. So when we look at the compliance of the left atrium, it is usually going to be normal. or low. So small volume causes a massive pressure rise and that can lead to pulmonary edema. So what happened to the left atrial size over here?
Normal.
So the left atrial size will be normal. So these two options are excluded. These could be the correct options if we have a chronic case when there is time, when there is sufficient time for the left ventricle to dilate or to accommodate blood. But this is an acute case, so left atrium didn't have the time to increase in size or to dilate. So the left atrial size is normal. So we are left with two options, B and D. This is clear.
Yes.
Yeah.
Then then we have the left ventricular size because now the left ventricle receive increased preload because we have discussed that left atrium has no time to dilate, so its compliance is normal or sometimes low. So small volume causes a massive pressure. When there is a small cavity and there is a lot of blood or pressure, it will cause a massive pressure rise and that can lead to backflow of the blood and can cause pulmonary edema. The left ventricle receive increased preload because now the blood is returning from the lungs, plus there is a recurrent volume present. So automatically your left ventricle receives increased preload, but again because left ventricle has not yet remolded or not time for dilation, so what will happen to the left ventricular size?
Normal.
Again, it will be dilated if we have time to remove. But because this is an acute thing, so the left ventricular size is normal in this case. So both left atrial and left ventricular sizes are going to be normal in acute phase. So now let's see that what happens to the left ventricular ejection fraction. The left ventricle is ejecting blood in two phases, the forward phase and then the backward, because there is a regurgitation. So when the left ventricle contract, the blood is pushed forward into the aorta, and then there is some blood that is pushed backward into the left atrium. So although the total stroke volume is increased, but not all the volume is being ejected into the aorta. Make sense?
Can you repeat that?
Yes. Now you have a lot of blood in the left ventricle. So the total amount of blood that is going to move out of the left ventricle or the total stroke volume is going to increase. But this is your left ventricle, this is aorta, and this is atrium, and this is a mitral valve. When the left ventricle is going to contract, yes, the stroke volume is going to increase, but not all the volume is going to move into the aorta. A lot of volume is going to move backward. So total volume is going to increase, total stroke volume is going to increase, but a large part of it is actually a regurgent volume, which is going to move back to the left atrium, not into the aorta. Clear?
Yes.
So the forward output actually decreases. But when we look at it, we'll see that the left ventricular ejection fraction will appear either normal or increased. Because the total volume is increased.
I'm not following this.
See, you understand this point that in case of mitral regurgitation, more blood is entering into the left ventricle.
Yes.
Okay. And when the left ventricle contract, it has two, because the mitral valve is not complete, is not closed properly. So when the left ventricle contracts, we have two pathways. Some of the blood is going to enter into the aorta, and some of the blood is going to move backwards into the left atrium. Make sense? This point is clear.
Yes.
So when we describe this volume, we will say that the forward output, or the forward volume, or the volume of blood that is entering into the aorta, it is decreased because some of the blood is actually moved backward. But when we measure the ejection fraction is actually the combination of both. When I say ejection fraction, I'm going to measure the total blood which is moving out of the left ventricle, regardless it is moving forward or backward. So the ejection fraction is going to be increased, or at least going to be a normal. It is not going to decrease because it is a total blood. Clear?
Yes.
That's why the option D is the correct option. This is clear?
Yes. Thank you. That was the confusion I was having too, because I was just debating if it was enough time for the compensation to be dilated. But it's clear. Thank you.
No problem. Okay, so I'll see you guys on Monday. Hopefully, inshallah. Take care. Thank you.
Thank you.
Thanks.